Anyway, I'm Dr. Marianne Harris from St. Paul's Hospital in Vancouver, and it's my pleasure and privilege this morning to be able to introduce the Clinical Sciences Plenary. Most of you, of course, probably know Dr. Marina Klein very well. She's a professor of medicine in the Division of Infectious Diseases, the viral illness at McGill University, and has a special interest in HIV and Hepatitis C co-infection. She's participated in a number of epidemiologic research collaborations, including CANOC and any Accord, and since 2012 has represented the North American region on the International AIDS Society Governing Council. In particular, I'm sure, again, we know Marina very well from her work in HIV and Hep C co-infection, particularly as the leader of the Canadian CTN222 co-infection cohort, which she's been running for 10 years now. So appropriately, this is the 10th anniversary of the cohort. It's given us so many really interesting presentations and data related to the interplay between HIV and hepatitis C and their treatments, really enriched a number of our CAHR conferences with many, many interesting presentations and, of course, international conferences and important research publications. And so I think on the 10th anniversary of the cohort, it's very appropriate to have Marina here to sort of tell us what's happened in the last 10 years and look at the next 10 years in the co-infection cohort. So Marina.
Thank you very much, Marianne, for that very kind introduction, and to the organizers for inviting me here to give this plenary today. It really is truly a tremendous honor. You'll notice that I've changed the title somewhat from what's printed in the abstract book, and that's really, as I prepared this presentation, it suddenly dawned on me that this has been 10 years since the inception of the CCC, or CTN222, or whichever you want to call it. And I'm so pleased to be able to share you our work over the last decade, but really even more, I'm excited to present our vision for the future for the next decade. We are talking at this meeting about turning the tide on HIV, but with hepatitis C, the tide has already turned. In fact, you could say that there's been a complete sea change with respect to the treatment and care of individuals with hepatitis C, if not a tsunami, where just the numbers and rapidity of change in terms of the medications that are being brought to market rapidly, which are going to completely, dramatically change the landscape of co-infection. So it's really an exciting time to be involved in this field, and really that we be able to attack it head on with such a great cohort that we've been able to establish over the years. These are my conflicts, if you can read them. I guess it doesn't seem to have projected very well, so I guess. Right, so the Canadian Coinfection Cohort Study, as many of you in this room actually know, because you've either been participants or helped recruit patients, is a prospective cohort that collects detailed data on sociodemographics, drug, alcohol use, treatments, and we actually link to vital statistics to obtain health outcomes, and now increasingly to administrative databases. And it started as a pilot study in 2003 at 3 centers in Quebec, and then in 2006 we expanded across the country to include now 18 centers. In fact, we're going to welcome a 19th center in Saskatchewan very soon, and have enrolled 1,200 patients as of January of 2014, with about 4,000 person years of follow-up. We have deliberately tried to reflect the Canadian epidemic to the best of our ability by recruiting participants from large and small primary and tertiary care centers in urban and semi-urban areas, in an attempt to also recruit marginalized individuals through things like the Équipe Mobile, which goes out to street affected people. And these 1,200 people actually represent approximately 10% of the estimated number of co-infected persons in Canada, and probably closer to 20 or 25% of those who are in regular care. So I think we have been able to create a highly representative picture of co-infection in this country. What started as a real focus on evaluating factors related to liver disease progression. So if we remember, 10 years ago, there was really very little we could do about hepatitis C. The treatments were not so effective, and our participants weren't achieving them. Things that were driving morbidity and mortality were really related to liver fibrosis progression and death. And so we focused principally on looking at factors related to disease progression, and in particular the role of antiretroviral therapy in that area has led now to really the building of a translational research program that kind of touches now on pretty much all the pillars of research across the board. So we've increasingly moved to look at issues in population health, health service utilization and access, and pharmacoeconomics, which is going to be a new direction for our cohort. We have projects related to social determinants of health. In particular, I would note the food security project that's being led by Joe Cox as a sub-study of the cohort. And of course, we continue our focus in the clinical area, evaluating non-invasive markers of liver fibrosis protection, predictors of liver outcomes, the increasing importance of comorbidities such as insulin resistance, diabetes, and other renal disease in this population, as well as, of course, hepatitis C therapy, and I'll finish in this talk by focusing on that. And with our colleagues in basic sciences, we have many collaborations formed using our samples, because we have a very large sample base of both serum, plasma, and peripheral blood mononuclear cells, to perform studies in proteomics, inflammation, and immune responses. Now, I put this busy slide up. You probably can't even read the numbers on it at all, but just to say, to show you, these are the direct and indirect partnerships of the Canadian Coinfection Cohort Study, or CTN222, that have been leveraged over the years. And I put this up principally to say, we're often very negative about the funding situation in Canada, but I think this is testament to how, in fact, you can really leverage funds across the various funding partners and make something very successful. So the cohort began as a pilot project in Quebec with a $35,000 grant from the FRSQ. And then shortly thereafter, in about 3 years with that pilot data, we were able to successfully fund the cohort through the CIHR and expand it across the country to become what's now the multi-center study it is. But since that time, we've been able to fund numerous sub-projects through either CIHR or CAN4, or with our industry partners, where we're looking at interventional therapies such as the Merck-sponsored raltegravir switch study, which is kind of based out of the cohort study. And in addition, to fund a whole host of students, postdoctoral students, master's students, and PhD students, again, through competitive funding awards from CIHR, CTN, and the NHRTP. And so I think it's just, particularly for those young investigators out there who think, oh, it's only a small, $30,000, $60,000 grant. You actually, with perseverance and hard work and lots of grant writing, because this takes a lot of grant writing, you can actually build things up to be. And we are now also partners with a number of other large collaborative initiatives in Canada, including CANOC. And so if you look at the bottom line figure there, that's about $12 million that we've leveraged over the last 10 years. And this isn't a single person effort. I mean, I'm here presenting data on behalf of all these people and numerous others whose pictures I couldn't actually pilfer from the internet last night. And just to say that this is really a team effort. Many of the individuals in this room are here, have either contributed either to the recruitment of patients, in leading the scientific agenda of the cohort, and in leading their own sub-studies. So without all of you, I wouldn't be here to present the data I can today. Apologies also to Mark Tyndall, who looks pretty grim in this picture, and I think that's because he's standing in the Ottawa snow, tired of winter, but it's okay, Mark. You'll soon be moving to sunny Vancouver. So now I'll just turn to paint a small picture of co-infection in this country. This is a distribution of patients in the CCC by self-reported mode of hepatitis C infection over the years. And really there hasn't been that much change in terms of the primary cause risk for acquiring hepatitis C, and that's really injection drug use, and it's illustrated here in blue. In red, you can see that the second most frequent mode of acquisition of hepatitis C is actually through sexual exposure, and this is principally among men having sex with men. Now, these are prevalent cases of hepatitis C that get entered into the cohort. So we can't say all that much about temporal trends because if we look, for example, at the sexual risk factor, it seems to be fairly stable over the years. So this doesn't really suggest that there's any changes in temporal trends, but that the overall makeup of the cohort is fairly stable. Injection drug use, as I mentioned, is the principal route by which people have acquired hepatitis C in our cohort, and in fact, 80% of participants have ever used injection drugs. At the last visit, so the most recent visit, 35% are still actively using. The cohort is reflective of the Canadian population, with the full exception, however, is that there's an overrepresentation of Aboriginal persons, representing approximately 16% of the cohort participants, and we know that this is an overrepresentation compared to the Canadian population, which is somewhere around 2 to 3%. HCV genotypes are principally genotype 1, which was traditionally the more difficult to treat genotype. That's changing, obviously, with new therapies. The second most frequent genotype is genotype 3, with a smaller proportion of genotypes 2 and 4. Now, if we look at HCV treatment status, I think it's quite interesting because in the literature, injection drug users in particular and those who have co-infection have been reported to be undertreated with respect to treatments, whereas we've actually done quite well. At enrollment, about 14%, or a total of almost 20% of individuals had either previously been treated or were on treatment at the time of enrollment. And if we look at the last visit, fully 35% of participants have actually received hepatitis C treatment. And this is hepatitis C treatment principally with pegylated interferon and ribavirin. We only have a very small number of patients to date who have received the direct-acting antivirals. But if of those treatments, because they're less effective, about 2/3 are still chronically infected because they failed to respond to that treatment. So if we look at the glass half empty perspective, what we see here is that almost 75% of our participants still have active hepatitis C replication and are still at risk for liver disease-related complications and other complications of hepatitis C. And this has really been borne out in probably the more sobering results from our study, and that is the very high mortality rate that we've observed. This slide shows the mortality rates. That's the dark black line, and in the gray, standardized mortality rates. So that's standardized to the Canadian population of the same age and province. And what you can see, as you would expect over time, overall mortality rates increase with age. So these are by age brackets, but that the standardized mortality rates are significantly higher, particularly among younger people, so showing that premature mortality in this population. So overall, co-infected participants in our study are at 12 times the risk of death compared to age-matched Canadians. And in particular, this is a problem for women, where they are 20 times more at risk of death compared to the Canadian population. And the principal cause of death in our cohort is, as what we expected, end-stage liver disease. It accounts for approximately 20% of all deaths. And this is closely followed by drug overdose. And that shows that there's, the two main issues in our population where we could potentially act is to deal with hepatitis C, and we still are doing not enough with respect to harm reduction. I should say that, going back, it's notable that AIDS actually has dropped off as an important cause of death in our populations. It just to show that, in fact, effective HIV treatment is possible even amongst patients who often have difficulties with adherence and are marginalized, and that we are able to actually deal effectively with HIV. And so that should be good news with respect to the possibility of dealing with hepatitis C going forward. And this isn't surprising that end-stage liver disease is an important cause of death in our cohort, because this is data from Rob Remus from Ontario, which estimates the numbers of cases and projected liver outcomes of cirrhosis, death, decompensation, and hepatocellular carcinoma. And as you can see over time, this epidemic is really only starting to peak, because hepatitis C, as we know, is a chronic infection. It takes many, many years to cause liver fibrosis and damage, and in fact is largely asymptomatic for those periods of time. And the only bad outcomes start to occur 20 to 30 years after infection. So we really are now at that time, as when bulk of the epidemic started to occur in 1970s, 60s, and 70s, and 80s. And we can expect to continue to see large numbers of cases of liver-related events out probably to 2030 until the peak of this epidemic starts to wane. That hopefully these curves can be dramatically modified by the introduction of curative hepatitis C therapy, but that still remains to be shown. In this study, we tried to look at specific risk factors for death in our population based on both behavioral and clinical characteristics at the last visit to see if there were areas in which we can intervene. And it's perhaps a bit hard to read at the bottom there, but what I want to use this slide to illustrate two things. The first is that women, for all risk factors, remain at elevated risk for death compared to men when you're looking at standardized mortality ratios. And that the highest standardized mortality ratios are seen in patients who are not on ART. Again, saying that if this is an intervention we know works and we need to use, and so that those are the patients we need to really target for adherence to therapy. And those who have pre-existing evidence of liver disease, that is end-stage liver disease at baseline. In contrast, the lowest standardized mortality ratios are seen among those who've successfully received hepatitis C treatment and those who've spontaneously cleared their hepatitis C infection, illustrating that hepatitis C itself is a principal driver of mortality in this population. So, one of the things that we focused on initially with the cohort was the impact of antiretroviral therapy, because at the time it was felt that a large part of the increased risk to progression of liver disease in the setting of co-infection was really because of uncontrolled HIV. And there was for many years the thought that if you could simply control the HIV, you could actually at least slow the progression rates to similar to those that are seen in hepatitis C monoinfection. But much of our work has suggested that this is probably not the case, and the reasons for that are still to be determined. But in this early study that we did with a postdoctoral fellow of mine, Huda Al-Mouri, we looked at the rates of fibrosis progression, and this is modeled as the APRI score, the AST to platelet ratio, which is a non-invasive surrogate marker for fibrosis, with the upper threshold of greater than 1.5 equaling fibrosis and a lower threshold less than 0.5 as being no fibrosis. And in green, you see the fibrosis progression rates over 10 years in hepatitis C co-infected patients compared to blue HIV mono-infected patients, and you can see there's a significant, as expected, increased rate of fibrosis over time. And then if we look by drug class, it appears that much of this is explained by exposure to boosted protease inhibitors. I point out that actually even among the HIV mono-infected patients, there does seem to be a slow, but not a rise to significant fibrosis, but there's a slow and steady increase in the APRI over time. And so this suggested to us that maybe cumulative toxicity from boosted protease inhibitors, perhaps through metabolic function or hepatic steatosis, might be contributing to liver disease in this population. We are not the only ones who have focused on this area and have looked at the role of CAHR in the setting of liver disease. This is an elegant study that was done by Vin Loray from the VAX cohort that compared patients who were fully suppressed on HIV therapy with hepatitis C co-infection to those who were hepatitis C mono-infected, and even after full virologic suppression, those with co-infection remained at twofold risk of hepatic decompensation. We have showed, and others, that in fact hepatitis C does not only affect hepatitis C-related outcomes in the setting of co-infection, but does seem to impact HIV-related immune reconstitution following the start of antiretroviral therapy. So this study, led by Martin Potter, who was a master's student and a CTN postdoctoral fellow, looked at the impact of hepatitis C viral replication on CD4 cell count recovery following initiation of HART. And on average, there was a 20-cell lower per year increase in CD4 cells among patients who had replicating hepatitis C compared to those who did not, suggesting that the chronic infection with hepatitis C is impairing immune reconstitution. Other factors that appear to be important in our population, and I've alluded to this already, are metabolic consequences, either of hepatitis C infection or antiretroviral therapy, and that's insulin resistance, which is increasingly being seen as a problem in our populations. And this study led by Mark Hull looked at insulin resistance as measured by the HOMO-IR score, so a HOMO-IR score of greater than 2, shown in the lower curve here, was associated with almost a 7-fold risk of progression to liver fibrosis in our population. So this to say that either antiretroviral therapy itself may be contributing to liver disease progression, but also that controlling hepatitis C may not be, HIV may not be enough in order to reduce outcomes in our population. We did, however, look at some things that aren't associated with fibrosis progression, which was actually probably one of our most highest hit study, but honest to be said, that's mostly on POT blog sites, and the number of hits to our website went up dramatically after the publication of this, and you could see where it was coming from. So a lot of interest from the marijuana community, but up until recently, it was kind of taken as, I wouldn't say dogma, but as one of the factors that contributed to fibrosis progression in hepatitis C was the use of marijuana. But all the studies up until that point had been cross-sectional. And so we had the advantage of having longitudinal data on marijuana exposure and could look at a group of patients without fibrosis or cirrhosis at baseline, look at exposure prior to the development of these outcomes and see if there was any association with exposure to marijuana. Because marijuana is frequently used by participants to alleviate symptoms that have been attributed to hepatitis C or to chronic pain. So one can imagine that if you're sicker with your hepatitis C, you're more likely to use marijuana in that setting, and that probably explained the previously observed association. And no matter how we looked at it, whether it was using surrogate markers such as APRI or clinical diagnosis of cirrhosis or end-stage liver disease, we did not observe an association between marijuana exposure and fibrosis progression. So I think what I've painted a picture of is that there's still going to be ongoing issues with respect to liver disease in this population unless we can actually target hepatitis C itself. And we are able, unlike HIV, to offer the potential for a cure in the setting of hepatitis C, and that's usually referred to as an SVR, or sustained virologic response. And there's emerging data from a number of groups, and this is the Spanish data published in Hepatology not long ago, that suggests that SVR leads to improvements in a variety of outcomes in co-infection, including overall mortality, liver-related mortality, hepatic decompensation, and there's actually a hint that perhaps even hepatocellular carcinoma might be reduced. We were interested in looking at some of the broader effects of SVR on other health outcomes in our population, and this is work done by Man-Hua Young, who is a master's student. She's recently defended her master's in the fall, looking at quality of life following treatment for hepatitis C, and among cohort participants, patients who achieved an SVR, were achieved improvements in quality of life scores as early as 6 months post-treatment that were sustained at 1 year post-treatment, whereas those who had no SVR, quality of life remained kind of stable and maybe slightly reduced over time. This degree of difference, it was a 10 points on the EQ-5D scale, was considered to be clinically meaningful, sort of akin to what you might see in patients who receive cancer chemotherapy and achieve remission. So this is probably important. In addition, there seemed to be broader effects. We looked at healthcare utilization in our population following treatment for hepatitis C, comparing patients who achieved an SVR versus those who did not. And in multivariate analysis, after you control for pre-existing use of healthcare services, because patients clearly have different patterns of this, inpatient visits and walk-in visits were significantly reduced among patients who achieved SVR. 80% reduction in inpatient visits. So this speaks to the potential for an important impact on health economic outcomes. But we have to take a little bit of caution here. We also looked at drug use and substance use in our population following treatment. And one of the things that we saw that was interesting is that among patients who achieved an SVR, so this slide shows at cohort entry the level of alcohol use. Prior to treatment, this was reduced in both groups because it's often counseled for patients to stop consuming alcohol while on hepatitis C therapy. And in fact, those who achieved an SVR seem to have done this more successfully than those who did not. But following achievement of an SVR, alcohol use increased dramatically and even to levels above baseline, suggesting that once you've cured your hepatitis C, the message about drinking seems to be potentially lost. And we have to be cognizant of this because these patients still have fibrosis and they could still be at risk for developing liver outcomes related to alcohol-related cirrhosis. And so I think harm reduction following treatment is going to be a very important issue. So it's clear that hepatitis C treatment is really what we need to be able to bring to this population to improve health in a broad range of levels. But how are we going to do that, and what are some of the challenges that we're facing in getting patients on therapy? We are interested in looking at how hepatitis C therapy uptake was occurring across the country to gain some sense about what are the potential barriers to access. And so in this study, we looked at variation between our centers with respect to treatment uptake. And what we've observed is that the magnitude of the center effects, and there were very diverse opinions about the importance of treatment eligibility criteria amongst our providers, could be significant barriers to treatment uptake. So to show you this in another way, the factors that were associated, the patient-related factors that appeared to be associated with receiving hepatitis C treatment were as follows. Women were significantly less likely to be treated, Aboriginal persons were less likely to be treated, and those who had ever used crack or cocaine were less likely to be treated in our cohort. But if you accounted for all these patient-related factors, that is the case mix at any given center, what we observed is that certain centers appear to be far more successful, if we want to use that term, at initiating patients on therapy than others. And on the left-hand side, you see that there are two centers. So these are ranked from 1 to 16, as in best to worst. I don't want to use that terminology too much. You can see there's a lot of overlap here. The vast majority of centers, you cannot distinguish between their abilities to do this. But there were two centers in two different provinces that seem to be standouts. So maybe these can be informative to us to determine what are they doing right that's actually getting more patients on therapy. The second slide actually adjusts for pre-cohort level rates of treatment. So that is if you actually had a site that had already exhausted all their patients, and that's why they're not starting any more patients in our cohort follow-up. Could that have impacted this? And no, that's not the case. These two centers still seem to be important. And if we surveyed the physicians who are the principal investigators at these sites to see what were the factors that influenced their decision-making in terms of initiating patients on therapy. And the first thing we see is the range of responses is so wide for the vast majority of these things that it's clear that even though we have consensus guidelines out there that suggest to us when and whom should be treated, the opinions held by different investigators are quite dramatically different. So you can see that, for example, genotype, where we rank 1 as most important, 5 as least important, was on average 3.5, so people considered it, but some thought it was completely unimportant and others thought it was extremely important. So there were really only two factors that seemed to be consistently rated as important by investigators, and one was the severity of fibrosis, so this is 5 most important, and 1 current alcohol intake, interestingly enough. And in fact, when we re-looked at this data and looked at centers according to whether they had availability of FibroScan, which is a way to measure liver fibrosis non-invasively, in fact, the availability of FibroScan was also associated with the likelihood of engaging in treatment of patients, whether that's because people who have bought into FibroScan and are measuring fibrosis are more likely to start patients on treatment, or whether, in fact, the availability of a FibroScan to allow you to assess therapy, the fibrosis levels, it has an impact on whether you start treatment or not. It's hard to say. But I think this points to the fact that we still have work to do, even with our providers for whom we think are experts in this area. Now, this was all about starting treatment. The past studies were all about starting treatment with pegylated interferon and ribavirin. And now we're moving into a new era of direct-acting antiviral agents. We looked at our cohort to see, in fact, who might be eligible. So one of the issues with the first generation of direct-acting antivirals is that they are difficult to administer for some patients. Because they're fairly complex, they still require the use of pegylated interferon ribavirin, and they have the potential for multiple drug interactions. And so we looked at the cohort according to whether patients were treatment naive or treatment experienced, and then step down wise to see who would still be eligible for treatment at the end of the day once you took into account the various contraindications to therapy. And the bottom line is that fewer than 50% of patients and fewer than 30% of treatment experienced patients actually would be able to use the first generation of DAAs. And I think this is actually shown in our cohort by the small numbers of patients who actually access these therapies. One of the principal drivers remains depression as an issue, and so that speaks to the fact that if we could remove interferon, which is the primary side effect that can cause depression, then we could actually probably increase the numbers of patients treated. Other issues had to do with decompensated liver disease, though, so we still have a large group of patients who are very sick and for whom treatments are going to be difficult to give. This slide just shows some of the sociodemographic and clinical characteristics of patients at their last visit that speak to this. I think I haven't focused on some of the social determinants of health, but one of our issues is low socioeconomic status. Most patients are earning less than $1,500 per month. There's still a lot of substance use ongoing, and we have a lot of decompensated liver disease. So these are still going to be ongoing barriers we're going to have to address going forward. In this slide just summarizes the types of barriers that I think we need to think about, and these may alter and change with the different types of regimens. The new regimens I'm going to address in a few moments with you are really going to help in a large number of these barriers, I think, because they'll be more simple and with fewer side effects and have less infrastructure needs potentially. But we still are going to have to deal with issues related to patient barriers, poor awareness or education around the availability and potential benefits of therapies. When people have no symptoms, they frequently don't seek care or seek treatment. Competing social problems and priorities, I think, are important, particularly housing and food security and financial. For providers, I think there's still work to do with respect to education, with respect to understanding how and when we can initiate therapy. Reticence to treat injection drug users, I don't think in the Canadian context is a really big issue. I think we've shown that at least 30% of our patients have already been exposed, suggesting that this isn't a big issue. But it is out in other regions of the world. And then increasingly, I think it's going to be structural barriers that are going to cause us difficulties with administering hepatitis C therapy. That is, as these therapies are extremely expensive, there'll be far more limitations placed on access. And unless we act on improving this aspect, I think we're still not going to make tremendous progress. Okay, I'm going to turn now to really talk about excitement in the new era of a real revolution in hepatitis C therapy. I think many of you in this room already know, and you've heard this more frequently now, that the landscape is completely being altered, and I've alluded to that already in this talk. Whereas pegylated interferon and ribavirin were really the mainstays of our therapy from 2010 onwards, what we can see is that these treatments are extremely complex and are associated with large numbers of side effects. In the green bar, this is the intermediate period that we've entered into now, where you pair pegylated interferon and ribavirin with a direct-acting protease inhibitor. But that doesn't only do more to increase the complexity with the numbers of pills required and side effects, but we're going to see a dramatic decrease in this complexity with the DAA combinations that are just coming onto market now. And this slide just shows that there's been a complete explosion in the developments of drugs in this area. And this is already dated if anyone can read the details on it, that there's in the center in terms of the approved drugs, you only have boceprevir and telaprevir, but now we've got other drugs approved, including sofosbuvir and cimeprevir, and these and several others that will be coming either to approval or to market in the next little while. And so we're really going to be, it's an era of plenty in theory, but we have to see in practice what that's going to relate to. And the biggest change here are twofold. One, and this slide shows you in yellow the duration of therapy for any given regimen, and in blue the efficacy of therapy. So with much reduced durations, that is now between probably 8 and 12 weeks ultimately, we see far greater efficacy with cure rates approaching 100% in a number of cases. And you see this is pan-genotypic. Depending on the regimen, we have regimens that are active against genotypes 1 through 4. And so this is a complete revolution in therapy and probably unprecedented in modern infectious disease, where we go from having really mediocre treatment to something that's so potentially curative. But without a change in the numbers of patients that get access to treatment, no matter how good the treatments are, we're not going to make a dent in the epidemic. This is a very elegant piece of work done by Dave Thomas. It was published in The Lancet in 2010 that plots the increasing cure rates over time, but shows that unless we dramatically increase access, the numbers of patients actually cured worldwide is not going to really move very much at all. And the biggest probably stumbling block to getting these therapies widely used is their cost. And this is a slide that was inspired to some extent by Steve Shapron, looking at cost per SVR, because I think it's a good way of thinking about this, because we can say, you know, sofosbuvir is the $1,000 pill, that's what's been named, and, you know, that doesn't necessarily put into context what is you can potentially gain from it. But depending on the genotype, for example, for genotype 3, currently 24 weeks of pegylated interferon ribavirin is quite effective, and about 70 to 80% of the time will achieve a cure. And so that's really inexpensive. So it's about $14,000 per cure. But if you were to give that same genotype 3 sofosbuvir ribavirin at about $110,000, that's the estimated Canadian price, it's $122,000 per cure. So you can see how governments are going to be faced with making decisions and recommendations about what indications for these therapies are going to be allowed. It's less clear that it seems that the new therapies actually are much more likely to be cost effective in the genotypes that have been traditionally very difficult to treat. And these are pure costs, I just to say, of the drug costs themselves. This does not take into account all the nursing time and the other ancillary costs. So it's a very kind of quick and dirty way of looking at this. But if we look at genotype 1s who are cirrhotic, I think you could see that there's a potential for this interferon-sparing treatments in particular to be potentially interesting, but we're still talking around $65,000 to $85,000 per treatment course and cure. And so this is not possible in the Canadian healthcare context if we were to treat everybody with hepatitis C now. It would just bankrupt the system. And so there's going to have to be judicious use of these therapies and targeted use of these therapies, and we're really going to have to understand for whom and when they need to be used. Or the costs are going to have to come dramatically down, and I think that's probably where we're going to have to go. So just to say that the therapies are very exciting, but we also have to keep in mind that once you have something very curative and simple to take, then risk behaviors may change. And we already know that this is just data among men having sex with men about the risk of reinfection following successful treatment for hepatitis C. And this is with PEG-RIBA treatment. So these are people who actually have undergone a relatively difficult treatment to take. That the reinfection rates are quite astoundingly high. And this is data that was presented last year at the IAS in Kuala Lumpur, showing at about a second reinfection even occurring in about 20% of patients who were infected. So if you think about $85,000 of treatment, and 3 times, this is, we have to start to think about how do we intervene to reduce these things. Injection drug using, perhaps not as high the rates of reinfection, and that it then depends on your context and how much harm reduction measures are available, but there's no question that hepatitis C cure does not prevent you to become reinfected, and so this is going to be an issue that needs to be figured into the mix. So I'm going to complete the talk today by just giving you a vision about where we hope to be going with the Canadian Coinfection Cohort over the next 10 years. I think the simultaneous development of multiple curative therapies for hepatitis C, as I said, is unprecedented in modern infectious disease. And it's really going to result in a highly competitive push to market of these new therapies. Clinical trials so far that have evaluated the DAAs have only enrolled ideal populations. So I have to say that the efficacy, all those numbers about 80 to 90 to 100% efficacy, and the pharmacoeconomic considerations will necessarily be optimistic. And I think vulnerable populations, such as those that are represented in our cohort, co-infected participants in particular, though this is actually changing with recent pharmaceutical trials, have traditionally been and will continue to be excluded from pharmaceutical studies. So observational studies are going to continue to have a very important role in conducting real-world evaluations of these therapies. And I think it's imperative that there is an independent and publicly funded response to the rollout of these medications that really evaluates the real-life impact for populations who are reflective of those who are really most in need, because if we look at co-infection, this is where the bulk of the morbidity and mortality is occurring. So there are several research questions that we hope to address over the coming years. What are the best models and approaches of care to treat co-infected patients with the DAAs? Which co-infected patients really require therapy, and when and at what stage in the course of their chronic disease should we be treating them in order to maximize the individual benefit? We need to better understand what the short and medium-term individual health benefits and risks are for these patients, particularly those who would have been sicker and not included in clinical trials, and what the medium-term health economic impacts of treating co-infected patients with DAAs are. So in conclusion, there are still a large group of patients who need hepatitis C therapy. And the interferon-sparing DAAs have really a tremendous potential to improve things for this population. I think that successful hepatitis C treatment is going to yield a range of measurable health benefits, from improved fibrosis, reduced liver and non-liver-related morbidity, better quality of life, reduced healthcare service utilization, and increased survival. However, ongoing risk behaviors and competing comorbidities might mitigate these benefits. And to maximize the medical and economic benefits of these therapies, we need to specifically target patients and improve our models of care accordingly. The comprehensive data on the real-life impact of these therapies that we will gather, I hope, will be essential to determine how and whom to best treat co-infected persons, and be critical to help us inform individualized care and prioritizing treatment decisions and guiding the allocation of health resources, which are precious. And our evaluation of care models will help us shed light on how best to engage and treat the growing numbers of vulnerable and marginalized patients who are going to require hepatitis C care over the coming decade, and hopefully set us up to the road to finally ending the hepatitis C epidemic. I can't conclude until acknowledging that all these numbers that I've shown behind them are actually real people. And I've selected some random things from the internet, but in particular 2 pictures, because I liked them both, of James Krepner, who I think many of you in the audience may have known and whose lives he touched. James was important, and I worked with him in helping to spearhead access to liver transplantation for HIV co-infected persons, and unfortunately he died before he was ever able to access a transplant. Though his legacy lives on, and now transplants are being offered to co-infected persons in Canada, those very, very few, and they really aren't the answer to this problem. They are an end-stage solution, and we need to act upstream from that far upstream. And the gentleman with the pill bottles in front of him is someone who has undergone a liver transplant. And just to show you, all we do then is replace, another chronic illness with 20 million pills is not going to be the answer. So we need to really fight to improve access to therapies and to remember always that harm reduction strategies are extremely important to prevent the epidemic from continuing. So really, I would like to just say in conclusion that I think it's a time and a call for action that, as was indicated last night in the opening session, I think researchers and clinicians and those persons living with hepatitis C and HIV really need to put pressure on our funders to ensure that we get equitable and timely access for these new therapies to all in need. And I'll just close by acknowledging the large numbers of people who have helped make this work possible, including the participants, foremost the participants in the cohort study, my co-investigators who are listed here, the study coordinators and research nurses at all the centers, and a particular thanks to Sahar Saeed, who's my right-hand woman, I guess you could say, without whom none of this work probably would come to be. And please visit us at our website, www.cocostudy.ca. And I'm pleased to take any questions. Thank you. Questions? No questions?
I think we don't have time for questions, so I'm sure that Marina will be happy to answer after this, the next session. Thank you.
Thank you very much.